Before we start, this is a disclaimer. This video is for educational purposes and should not be used as medical advice in treating conditions such as asthma or any other conditions mentioned in this video. Alright, so today I want to talk about asthma. Asthma, as defined by the WHO, is a common lung condition defined by sporadic breathing difficulties. It often presents in childhood and can present in early teens and later adulthood based on the individual. It is often caused internally by swelling of the airways, which bring air to and from the lung, which then leads to breathing difficulty, which may present as shortness of breath, coughing, wheezing, right? These are the common conditions noticed in asthmatics, right? So today I want to on the zones of management, right? So the zones of management protocol came about from persons who treat asthma, and they use it as like a stepping stone to determine when do you go to an ER, or when do you go to the hospital, or when do you call your doctor, right? So with that, zone 1 is defined as minimal symptoms. This is where you have some chest tightness, but it doesn't affect your day. From there, you have zone 2, which is marked by significant difficulty in your ADL. They may be affected. However, you get some relief from using your rescue inhaler. Zone 3 is marked by when the rescue inhaler or the long-acting steroids no longer provide relief, and this then progresses to an asthmatic attack, which requires medical attention and intervention, right? So with that, there are many aspects to break down in that. The aspects that I want to break down today are self-management from a patient perspective, as well as education on self-management from a physical therapy student, intern, or new grad perspective. These tips you can give a patient, or a patient can utilize to help manage their symptoms, right? So in the zone 1, where you're having chest tightness, physiologically, this normally is marked by swelling of the airway, and this can be mild to moderate, and based on the severity, it determines how much of your ADL activities of daily living is affected, right? With that, you want to ensure that from a patient perspective that you're focusing on exhalation, not inhalation. So what happens is that air will naturally diffuse into the lung regardless of if you try to take a deep breath or not. That will allow your body to still conduct gaseous exchange. However, when the airway is narrow, you start to have what's called air trapping. And that is when you start to see your chest expand and your breathing becomes difficult because you're having difficulty exhaling. And because you're having difficulty exhaling, air has more difficulty getting in, right? So with that, you want to ensure that you're focusing on exhalation. What happens physiologically is that as the airways continue to swell, they continue to exude fluid, and that fluid is what then triggers the wheezing. So it's chest tightness, then wheezing. If it is that you're not suffering from a flu infection or any other type of infections. So that would just be a naturally intrinsic or extrinsic reaction to of the asthma an asthmatic lung, right? So with that first phase, you're in the zone 1. Your chest is tight, you notice it, you're moving around, but you're having some noticeable change of breathing, right? Or your breathing becomes more noticeable to you, right? In that phase, a simple tip I'd like to emphasize or exercise that asthmatic patients can do is to work on their exhalation. So what you do is you inhale for like 2 seconds and exhale for 4. So what that does, it gets out all the stale air, allowing fresh air to re-enter the lung and help to clear whatever is blocking it, or just to improve the comfort of your breathing. So that looks like this. And then you're exhaling to the point where your diaphragm contracts, your abdominal muscles tighten up, and your chest is maximally compressed. That helps to push out any old or stale air that is becoming trapped by the swelling of the airway. That then allows space for new, fresh air to enter those spaces. What you will also notice by doing that is that when you go, you will somewhat feel like you need to cough after returning to normal breath. That is the fluid or air or whatever exudate is coming from the swelling being pushed up, and you need to cough that out. The longer that stays in the lung, the more difficulty you will have, right? So these tips are tips that I use personally because I also have asthma, right? So learning to self-manage myself over the years, this is my first go-to, right? Before going for my rescue inhaler. So it's and then you increase the force. If you notice when doing that, you hear a wheeze sound. You want to be gentle with that. Do not force yourself into a wheezing episode. So, right? And then for the physiotherapist teaching the asthmatic patients, be mindful of that. That wheezing sound, be mindful of it. Do not overexert on it. So that can trigger a spasm that then leads to full-on wheezing. But in zone 1, that is unlikely, but for zone 2 and 3, be careful. Right, so moving on to zone 2, this is where your ADL, activities of daily living, become affected. Right, this is where your walking becomes a little more laborsome. This is where your breathing is a little more laborsome. This is where your peak expiratory flow starts to decrease. For many of us in the third world countries, we don't have access to a peak flow monitor, so we wouldn't know what a decrease is. What we normally notice is that our words and sentences get shorter, and then from there, our walking becomes a little more difficult. And this is where most asthmatics start to reach for their rescue inhaler, right? The rescue inhaler is another aspect of management, right? I've seen good usage of the rescue inhaler as well as poor usage of the rescue inhaler. I've seen persons puff, 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 and exhale it through their nose. It does no benefit there. That is just cycling through your mouth and going back out through your nose. The rescue inhaler needs to go down into the lung and penetrate the airway to allow it to relax. So when you puff a rescue inhaler, right? So you exhale, puff it into your mouth, exhale, allowing that air to go into your lung, right? And then allowing those microparticles to penetrate the airway and then cause it to relax, right? If you just cycle it through the nose, your nose is not what is congested, your nose is not what is affected, and it will provide no relief, right? So sometimes as physical therapists who do not have asthma, we can't relate to the instruction as it should. It says it in the paper, you're just going through the motion, telling the patient what to do. But you have to really understand that some of these patients really don't know better, and you have to ensure that those basics are covered. Otherwise, your intervention will not be as effective, right? Going from there, we go into zone 2, persons rarely come to the hospital unless it's progressively getting worse as in the case of a respiratory infection. Right. So zone 2 can last for up to 48 hours depending on the nature of the spasm. This can be relieved by rescue inhalers once it's not an acute chest infection or anything like that. Then from there, you have zone 3, which is where they present to the hospital, right? So zone 3 is twofold. For the patient, you want to continue to do the basics, which is focus on exhalation, ensure that you're inhaling the nebulization in the hospital, right? So when they do nebs you, don't just have it passing in and out your nose. Really take deep breaths so that nebulization, that saline plus whatever else medications they're giving you in it actually goes into the lung to help it to relax. Oftentimes I'll see asthmatics be in the hospital like this, and it's just going into their nose, out through their mouth. Nothing is penetrating because you're compressing the chest, not taking deep breaths. Yes, you're in a little difficulty breathing, but at the same time, try to sit up and take deep breaths, right? You want to really get as much of that nebulization into your lung to help the muscles to relax. And from there, decrease your work of breathing, which is the exertion, as well as your breathing comfort, right? And then for the physiotherapists, right, there are three main things I want to touch on. One is instruct the patient when they're being nebulized on how to actually do make the most of it. So chest up, deep breaths, long expiration, get the nebs in, get as much air out, get the nebs in, get as much air out. That will help to resolve the asthmatic attack in a quicker and faster time period. Then two, be mindful of mechanical vibration. So mechanical vibration is the device most hospitals use, and you have it and you go to the patient. The position that you vibes the patient in is a big factor. In the A&E, sometimes you can't get proper space, so there's no sideline or anything like that. That is not possible. But you still want to be effective and efficient when you're vibing. So if the patient can raise their hand, really lift up that hand and get the lower lobes, especially on the right side. I'm demonstrating my left, but especially on the right side. Really lift up that hand and get those lower lobes, anterior and posterior, and that middle lobe. That will help to clear whatever secretions may be bothering that section. And once that goes, the breathing comfort gets better, right? That's in a sitting position. If you find the patient laying down, please to utilize postural draining, left sideline, right sideline, as well as your mech vibes, right? In the sitting position, the mech vibes does a good amount of work. Let's say a positive 2 net flow of secretion. In the postural drainage position, that can increase to up to a positive 6 net movement of secretions, and that will help the patient a whole lot more than you just going to them and having them sit at their bedside, right? These patients are often miserable and difficult to deal with. I know, because the breathing is difficult. We are fighting to get every breath in, and sometimes our ears are turned off and we're not listening as we should. But please be firm in your intention. Explain to the client that you're trying to help them and you're trying to help them as best as possible, and that includes them cooperating with you, right? Please be patient with us. We're not always listening as we should. It's not easy fighting for every breath that you have to take. That is 2. And 3, unless it is impossible to get a Glove PEP, a Bubble PEP, please reduce your usage of a Glove PEP. The reason I say this is based on my years of practice and what I've seen in the patients. So when I was young and starting out, I would give everybody a Glove PEP. Regular persons, COPD, asthmatics, everybody got a Glove PEP because it was quick and easy to make, right? That's another thing. The design of the Glove PEP is also another big factor, but in another video I'll touch on that. Right, everybody was getting a Glove PEP, but then with the Glove PEP, you are creating positive expiratory pressure, but at the same time, it is not fluctuating. So imagine an asthmatics who is currently having ear trapping, right? And then you're gonna ask them to blow into a Glove PEP. Yes, you might get some secretions out, but the glove is resisting and pushing that air back in. So it's gonna go through the pores of cotton and then further inflate those alveoli that are not getting their regular gaseous exchange from the bronchioles, right? And that is gonna cause further ear trapping and then cause the chest to expand, and the patient is now in more difficulty. I am a big fan of Bubble PEP. The first world standards is actually a Flutter PEP, but that is not readily accessible in most third world countries. So a Bubble PEP is where you you use either a cup or whatever you can find, and you get a 12 to 16 cm column of water, right? And then from there you insert a tube into it, not a straw, because a straw is going to be too close and it's going to cause the place to wet up. So suction tube, a NG tube, whatever tube you have available, you insert that into it. This is the same technique as when they're in zone 1 and they're learning to inhale and then exhale longer. So they're inhaling and they're exhaling as long as they can. In the beginning, this is going to be very difficult because they're having difficulty breathing. And then the breathing will probably be like, the exhalation will probably be like a 1 second. But your aim is to get that expiration ratio to 2 seconds to 4 seconds, and building up to a 1 to 2 ratio. 1 second inhale, 2 second exhale, or 2 second inhale, 4 second exhale. And that helps to clear the airway. The difference with the bubble PEP is that the fluctuation in the water pressure allows positive movement while not creating excessive back pressure, which then further complicates the ear trapping versus the glove PEP, right? So the glove PEP, the ear trapping will increase. The harder they work, the harder they exhale, the more backflow is there. Ear gets trapped in areas that are already poorly ventilated because the pores of corn bypasses the blocked area and just puts the ear in the alveoli. And then from there, the blockage doesn't allow it to come out. And every time you exhale into the glove PEP, it just repeats the cycle, and the alveoli continue to expand until the chest is maximally inflated. And then no air is going in or out, and that can cause further complications, right? Going from there. So bubble PEP, and then from there, please to encourage the patient when walking away from the patient. These are from my physiotherapy students and interns and new grads. Please to encourage the patient when you're walking away from them, because fighting for air sometimes leads to some level of depression, and then from there, they are there and they're just like, I just want to give up. But then you come to their bedside with a ray of hope. They have, regardless of whether you see that immediate effect and intervention, you have somewhat changed the level of comfort of their breathing. And from there, just inspire them to continue to push on, so that next time you come to them, they can say, after you left, I really felt better, I was breathing more comfortable, and I couldn't wait for you to come this morning to help me further, right? That is something that I've seen. That is part of what makes the profession rewarding. And from there, you just want to ensure that you're helping persons and encouraging them. You won't get extra pay for it, but it makes a big difference and your blessing will increase. All right, that is all I have to share for today. Thank you for listening. Thank you for tuning in. I hope this video was rewarding and informative to you. Thank you for watching.